Dr. Divya Khanduri. Yeah. So Dr. Divya will be presenting a case on Toxoplasma neuroretinitis case series. Is intravitreal a good alternative to classic oral therapy?
Good morning everyone. So I'll be presenting Toxoplasma neuroretinitis case series, and we'll see in the further. So neuroretinitis is commonly due to infectious causes. Due to toxoplasmosis, it is very uncommon. Typically ocular toxoplasmosis will present with a headlight and fog appearance with white focal retinitis over the overlying vitreous inflammation and adjacent pigmented retinochoroidal scar, vitreous inflammation, secondary non-granulomatous iridocyclitis can be there, KPs can be seen, ocular hypertension and retinal vasculitis can also be seen. But in atypical cases, we see retinochoroiditis, papillitis, neuroretinitis, retrobulbar neuritis, scleritis, retinal detachment or punctate outer retinitis can also be seen. So, moving on to our first case, the patient was a 48-year-old male who presented to the IOPD with complaints of painless progressive diminution of vision in the right eye since 2 months. He had a history of pet dog, and he was a hypertensive. On antihypertensives, he had controlled hypertension. On examination, his BCVA was right eye was finger counting close to face, and left eye it was 6/6 partial, and in his intraocular pressures were normal, and slit line examination anterior chamber findings were normal, but we could see vitritis +2. So his fundus photograph here shows that there was a vitritis +2 with massive disc edema with blood margins, and superficial flame shaped hemorrhages and macular edema were seen. Active choroiditis choroid retinite patch was also seen inferior temporal to the fovea, while the left eye was normal. On OCT at presentation, his OCT showed a dome-shaped elevation below the RP, showing the choroidal thickening and disorganization of the outer retinal layer, which showed that it is a chorioretinitic patch. There was a hyporeflective space, that is subretinal fluid was there, and subfoveal deposition of hyperreflective spots were also seen. So moving on to our second case, we had a 50-year-old male who presented to the OPD with same complaint. He had a history of pet cat. There was no systemic diseases, and on examination his right eye vision was 2/60 and anterior segment was normal with vitritis +2. His fundus photograph showed that there was disc edema with hyperpigmented active lesions in the parafoveal region with hemorrhages around it. And on OCT, it also showed that there was a disc chorioretinitis patch. Subretinal fluid was seen in the right eye, and ERM was also, epiretinal membrane was also seen. His central macular thickness was 368, and his left eye had normal findings. And another case, which was a 29-year-old female who presented with the same complaint and the history of pet dog with no systemic examination. On examination, his left eye, her left eye was 6/60 vision, and her anterior chamber findings were +2 reactions, that is uveitis was present, stellate KPs were seen, vitritis was there. So her findings is this patch with 2 disc diameter in parafoveal region. Her OCTs showed the same picture with few cystic lesions. Then all 3 patients had history of painless diminution of vision, pet had vitritis, and typical choroiditis scarred lesion were absent in these cases. So we investigated them, and the serologically and anti-toxoplasma IgM and IgG were positive, and we diagnosed them as left eye toxoplasma neuroretinitis, and we treated them with intravitreal clindamycin and dexamycin on presentation, and repeated the injections at 1 and 4 weeks. And on follow-up at 1 week, we can see that disc edema is resolving, the patch has been resolved. On 2 week, the case 1 showed that visual improvement to 6/12 and decrease in disc edema, as well as the hypopigmented patch and hemorrhages. At 6 weeks, there was complete resolution, and second case also showed the same thing. Then third case, we can see that there was resolving of the chorioretinal patch, and at 4 months now the follow-up, there was a complete resolution of the active lesion with scar formation. So so we can see that without trimethoprim and pyrimethamine, we have treated the patient with IV intravitreal clindamycin and dexamethasone only, and thus we have got the good results. So we came to the conclusion that since there are less studies, further perspective clinical study should be needed to validate the efficacy of intravitreal clindamycin as first-line treatment for the cases of toxoplasmosis.
So the rationale in giving a more invasive form of treatment?
Ma'am, actually the thing is that the patients were far away from hilly regions of Uttarakhand, so they had a less follow-up visits, and they were keen for immediate treatment and less follow-up. So we just asked them to come for in intravitreal injections and then follow up at 4 weeks and 6 months. That's it.
See, when you give, when you're giving an invasive treatment like that, first of all, are we sure about the diagnosis? That's very important.
Right,
so you could have a differential in these cases. It
Yes,
could be
ma'am.
candida.
Yes, ma'am. Tuberculosis,
It could be any,
infectious and
tuberculosis,
autoimmune, we both
syphilis.
can. Right,
So
ma'am.
it's okay, you've
Yes,
given clindamycin, but that is invasive as she said, and there is a risk of endophthalmitis also with each injection. So we have to be reasonably clear about the diagnosis. In the first case, there was very severe manifestation.
Yes, ma'am.
So when you give steroid along with that, when you don't have a clarity on the diagnosis, could there be a worsening of the disease if the diagnosis is different and now you've added steroid as well?
Right, ma'am. It can be if it is infectious disease, so it
So
can.
we not just give clindamycin and not give dexamethasone? You can give oral steroid if you want,
Yes,
so
ma'am.
that you can at least stop when
Add
you
up
want.
the.
But you cannot withdraw dexamethasone that you have injected.
Right,
So
ma'am.
I would say that just clindamycin would be good enough. And as Madam said, probably oral therapy is good. If in cases that are intolerant
Yeah,
for any reason, possibly we can
and
add it.
non-compliant.
Yeah, because every intravitreal carries a risk of endophthalmitis also.
Right, ma'am.
It's not, and clindamycin we have to reconstitute. It's not available like Lucentis or Eylea. So when we reconstitute, the risk of endoph goes high.
Yes, ma'am.
But overall, yeah, it's, I have used clindamycin quite a lot now. And yes, the response is very good, and the side effects of the systemic therapy are all avoided.
Less. Yes, ma'am. Thank you, ma'am.
So we should be cautious when giving periocular steroids, especially in patients with toxoplasmosis, without giving anti-infective drug. It can flare up
We
the
covered
infection.
it with the antibiotic.
Any infection actually.
Any infection,
And I think
more so.
with intravitreal,
Right.
if you are giving clindamycin, the systemic treatment is also important because toxoplasma causes so many things.
Right, ma'am.
Though
The-
currently, I mean, if patient is intolerant, you can just give intravitreal also.
Yes, ma'am.